Good morning, everyone, and thank you for this opportunity. My name's Shirley Anastasi. I'm the Manager of Clinical Governance with Metro North Mental Health. I'm here on behalf of Associate Professor Brett Emerson, who's the Executive Director for the service, and he offers his apologies, but would also like to thank Partners in Recovery for the opportunity to come and talk about what's been going on in mental health and where we're heading, and I guess the opportunities we see for ongoing partnerships with the NGO sector. I guess a lot has happened in the past 12 months. We're going through yet another organisational reform. So whilst there's clinical work and good clinical work being done with consumers every day, we're doing this on a background of extreme change, high levels of key performance indicators and all of that sort of thing. We're very aware that we actually are working quite hard, so that we need to work smarter and not harder, and that the opportunities to work smarter is with the NGO sector, and that considerable investment has been placed and considerable trust has been placed in the NGO sector. In mental health services in Metro North, we're moving away from that sort of case management or case manager terminology even to mental health clinicians to signify the difference between, I guess, the expert clinical care that we should be providing and that there's a lot of case management and care coordination occurring in the NGO sector. So there's lots of little subtle changes, there's huge organisational ones, and today I'm here to talk to you about what the new structure looks like and to let you know about some of the work that's occurring. We know that despite all our efforts, we have some consumers that are still falling through the gaps, and again, Brett Emerson would like to impress upon the sector that we are really very keen to work with everyone to try and improve this. Okay, so this isn't the most exciting part of the presentation, but it just gives you an idea of what's going on and where we've come from. So there was a huge national reform agenda across Australia where health districts became hospital and health services, and we now are accountable to a board. And in fact, as of 1st of July of this year, Queensland Health employees actually now are employed by a board and not by Queensland Health. So it's a change in that dynamic, and I guess our accountability to a board of very esteemed people who are from the community, who have clinical backgrounds, who are making sure that we're doing what is expected. Queensland Government put out a blueprint for better healthcare in Queensland, and their vision is that it's one hospital and health service providing a quality service for many. So we're moving away from this facility-based model where you might get something from Redcliffe Hospital, you might get another service from Caboolture, you might have to go to Royal to get another one. We're looking at how services can be streamed so that people have easy access and get the most timely care. The word streaming, I'm not too sure how to define that, but there are 9 clinical streams, so we're moving away from Redcliffe, Caboolture hospitals, Kilcoy hospitals, Prince Charles, Royal Brisbane, to looking at the clinical, where people get their clinical services and how they get these services. So mental health is one of the 9 streams. But they've acknowledged that in this change period, they still need to have people that are executives at each of the facilities. So they're continuing to have executive leadership at Royal Brisbane. They've combined the executive leadership for Redcliffe, Caboolture and what's called subacute services, which is things like the Coimbra nursing facilities, and so that's all under one banner. And Prince Charles, Caboolture and Kilcoy now have one executive facility-based manager. They've appointed a range of clinical and professional leads as well. So, whilst all this is happening, they're actually also looking at how we're funded, which I guess, whilst there's been a lot of investment in the NGO sector, they're now looking at how we're delivering services in the public sector. And in the past, we were funded historically. You got a budget last year, price index increases, you get a little bit more budget next year. They're now saying that we're going to be subject to what's called activity-based funding. So we're no longer going to be based on what we did the previous year and a little bit more. We're going to be looked at from every angle around what each service costs. And this has been really challenging for mental health. Brett Emerson likes to say that no one in Australia or in the world has ever been able to cost what a mental health service costs. So we know, a knee replacement takes 3-4 days and it's its amount of rehabilitation, and you can put a cost to that, but it's very difficult to do that with mental health services. In saying that, Queensland is trying to do some shadow modelling around what activity-based funding. We're trying to get ahead of the game before we're told what we're going to get, so that we can go and say, well, we've actually modelled this, and this is how much someone with schizophrenia first episode costs to treat. And we've got that mix of inpatient and community. It's seamless, whereas in other areas you may get your treatment, your knee operation in hospital, and your physio or rehab is either through a community outpatients or in private areas. We need to cost what it costs to keep someone well, as they sometimes go in and out of the hospital and have community support. There's a national body called the Independent Hospitals Pricing Authority, so they're looking at that as well. We've also been asked to, look at how much activity we're actually conducting on the ground that's directly involved with consumers. We have a very big database which no one really likes. It's called SIMA, or some people call it SIMHAHA. It was never meant to be a clinical note-taking or documentation database, but it is being looked at to account for how much face-to-face time our clinicians are having. It doesn't take into account things like travel, so we're actually now participating in another study to follow people around as to exactly what they're doing and how much time is actually spent with a consumer or a consumer-related activity. The system doesn't really acknowledge well when you might have a coordinated care system with 4, 5, 10 different parties involved, and the consumer may not even be involved sitting in the room at that point, but how do you collect that? So, as I said, this isn't the most exciting part of what I can talk about, but it gives you a bit of an understanding that whilst we're trying to provide care, we're being watched, stretched, measured, observed from every angle. So streaming was a long time coming. They started talking about Metro North would be a stream around mid-2012. The official date that it started was the 1st of September. So we really don't have a lot to report about what the mental health stream looks like. In saying that, mental health has been well ahead of everyone else. So the executive, led by Brett Emerson, decided 12 months ago, or 18 months ago, to start meeting as if we were a stream. So the executive management team have been in place. They've been meeting very regularly. We meet every Monday. And they're one of the first streams to be given a budget and HR. What this means is that Brett Emerson now makes all the decisions for mental health in Metro North. It's not going to the executive director of Caboolture Hospital and then checking if Prince Charles Hospital agrees or if Royal agrees or not. It's now decisions are made for the best interests of Metro North mental health consumers. The other good thing as a larger group is that problems now are problems shared. So we're cutting down those barriers, and mental health has been doing this quite well. I don't believe the other 8 streams are at this point yet where they're still all coming to grips with being in the same room together. But we are responding to problems. It's no longer, oh, well, that's Redcliffe or Caboolture's problem. We sit here at Royal. It's now an all-of-service response. So, for example, since the beginning of this, I think it was the beginning of this year. Since the beginning of this year, the psychiatry registrars from Prince Charles and and Royal Brisbane have been supporting Redcab to do the after-hours on-call roster. So Redcliffe Caboolture Mental Health Service has a very difficult time and huge turnover with doctors. I think Royal Brisbane has 29 registrars or doctors on the books. Prince Charles has 22, Caboolture has 13. So when you're doing on-call, it may not seem like much, but if they can help reduce you being on call 1 in 13 instead of 1 in 16, that's just going some of the way to showing that we're working now as one joint service. So that's been happening. A new psychogeriatric position was appointed to Royal Brisbane they felt that they didn't need it as much as Caboolture did. So that position now supports the psychiatrist at Caboolture and goes out to Cowinda, I believe, and sees patients there. So there is a lot more sharing between the service. We've still got a way to go. There's still the mad grab for beds on a Friday afternoon and, dare I say, hiding or amending the truth about who's got vacant beds, but we've also got a process in place there, because now we're seeing that if you have a vacant bed at Prince Charles and there's a consumer who needs that, but it's a Royal Brisbane person, we're no longer in these silos of, well, it's our bed. So again, in anticipation of streaming, we had a review of the mental health service by some people from Victoria, came up and had a look at how the services are functioning and made some recommendations around that, which I can talk a little bit about later. We now have the alcohol and drug service combined within the mental health service. Previously, it was attached to the Prince Charles Hospital, so it reported to Prince Charles. It sits in Byella in Roma Street. It's a statewide service, but it also provides Metro North positions. And since Metro North has come together, it's been identified, for example, that there were limited alcohol and drug nursing positions. So one of the first things that has happened is 2 new CNC positions appointed to Caboolture and Redcliffe Drug and Alcohol. So again, that response about trying to even out the resourcing so that people have an equitable service response. Okay. So just to give you some fast facts about how big we actually are now, Metro North is a catchment of at least 900,000. The budget for Metro North is 150 million, and there's over 1,000 staff employed. We provide services from perinatal, child and adolescent through to adult and older persons. Of course, inpatient and community, and we also have the inner city homeless team that's based within the Royal Brisbane service, but it covers that area. And then we're also a statewide specialty hub for eating disorders, forensic services. So the forensic service and all the court liaison and the community outreach, they provide statewide support, but they are attached to Metro North, so they're under the responsibility of Brett Emerson as well. So we now have 330 beds in total, so we have a range of acute beds, still not enough. We're struggling with bed blockages. We have a system where we know how many people on average to expect each week. So at Royal Brisbane, they need to discharge 5 people every day. At Prince Charles, 5 people every day, and at Redcliffe Caboolture, at least 4 every day to meet the demand coming in through the front door. And when that doesn't happen, there's some serious shuffling going on a Friday afternoon. Everyone does get accommodated, but it's still very tight, even though it looks like we have a lot of beds. 179 acute sounds like a lot, but it's not. We have 12 adolescent beds, which are statewide beds, so that's not enough for the state. And they have a longer length of stay, young people and I guess older persons, so that can cause some blockages. We have 2 secure mental health rehabilitation units in our health service. So one is based at Prince Charles and has been there for 12 years plus. And then there was the new facility that was built at Caboolture campus. And these facilities support people with the longer term sort of treatment resistant, perhaps pose a risk to themselves, people who have the opportunity to be in a longer term rehabilitation program and are gradually mainstreamed back out into the community. We have access to some long stay psychogeriatric beds at Cowinda, and we also have 16 statewide drug and alcohol detox beds. So 16 again is not much for the state, but they are attached to the Royal Brisbane campus. People come in for maybe a 5-day detox and then get ongoing community support. So, and of course we have a range of community-based services. So just to give you an idea of what we now look like, we have a single point of accountability with the Executive Director, and then there's an Operations Director and a Clinical Director at each facility, including drug and alcohol. And we're starting to move towards some state service-wide services. So, for example, we have a perinatal position at each facility. They're on their own. They've now been, I guess, brought in under the banner of it being a coordinated health service-wide facility. We have a resource team, so that's the team that has all of the positions around service integration, who work closely with partners in recovery and other NGOs, dual diagnosis coordinators, and they've been brought in together again so that one dual diagnosis coordinator isn't doing something different to someone else just 10 kilometres up the road. So we're looking at reducing that variation. So there's a number of positions that go across the service. I won't go too much into that. You can read them there. My position is a new position that was created to support the executive to do all of this work. So you can imagine we have 4 sets of procedures on safe home visiting, for example, or 4 different forms used to record a review meeting. So we're now in the world, until the next government changes us back, of aiming to bring those procedures and policies and forms so that we don't have variation, so that someone who gets a service at Redcliffe gets the same service or similar service. We need to be flexible with local needs, but at Royal Brisbane. So there is a copy of our structure available to you on your seats, just to take away. It's a bit easier to see than on the slide. But it's just to show you that we've maintained the 3 facility-based mental health teams and their teams, so Redcliffe, Caboolture, Prince Charles and Royal Brisbane. We then have this range of service-wide teams so that we can already start to reduce variation in all of those areas. Alcohol and drug is also another big area, as I mentioned, because it has the mix of statewide and Metro North services. And then there's a very strong research focus. I think in the last year, there were over 70 research and evaluation activities that were undertaken. So it's a very big area, lots of partnerships with different areas. So you can take that away. Again, I won't read through all this, and I'm assuming these presentations will be made available. These are the strategic priorities that the executive have committed to for the next year, and I guess that 2 in particular rely heavily on collaboration with the NGO sector. So it's very, very high on our agenda. Particularly item 4, or strategy 4, which talks about the recovery, reducing stigma, partnerships. So I've just put these up so that you can be familiar with the fact that we are committed to working in partnership. Okay. So the key principles of the reform are around accountability, transparency and efficiency. So they aren't usually words that we like to hear when we're talking about real people who are suffering with mental health conditions. As I said, this is all in the background of what we're trying to do. So we have developed a number of mechanisms that we want to make sure that we know how well we're doing every day, every month and every year. And we've actually put the responsibility and the ownership back on clinicians and teams. So again, it's an all-of-service approach to make sure that we're improving the outcomes for people. We've actually created quite a few dashboards, and I'll show you a couple. We think they're interesting, but they actually can show how we can drill down into how a team is performing in relation to a certain target around, for example, discharge summaries within 48 hours. It's an interesting phenomenon in mental health. I think if you experience a physical health condition, you've had a knee replacement, you pretty much walk out with a discharge summary in your hand to take to your GP to, what your medications are, what your rehabilitation requirements are. We don't know why it doesn't happen in mental health, but discharge summaries are quite tricky for psychiatrists. So one of the performance indicators is we measure the percentage of discharge summaries within 48 hours. Why that's important, as you know, is that continuity of care. So it does have meaning for the type of care that someone will get on the ground. I wanted to show you the dashboards, and I guess to say they look really pretty and fancy, but I did want to acknowledge that having fancy strategic priorities and fancy dashboards, no doubt everyone's interested in, is this actually working to help the care that we're delivering? And I guess it hasn't escaped our attention that at last year's Partners in Recovery Forum, the topic 3 out of 7 that received the most votes for progressing was around discharge and transition. So we know that we have a lot of work still to do in that area. I'm also aware that there's a co-create session that's occurring today. Is there one on discharge planning? There was at the previous one. And we hear it from consumers and carers and organisations saying that we're not doing a very good job in discharge planning and transition. So I guess that I wanted to show you, and I probably still will, some of the work that we are doing, and that there's lots more opportunities to partner up with the NGO sector. I think I should wait. Okay. One of the presentations that you will hear about, are you hearing about Step Up, Step Down today? Yes, sorry. I've attended the previous one. So one of the recommendations of the review of the mental health service was that we look into a Step Up, Step Down service, an alternative to admission. And we've certainly been very pleased that there's been the opportunity for Brisbane Housing Company BHC to receive innovation funding. So that's one area that we're partnering with. One of the other recommendations is about the implementation of a single access number for the state. So the mental health branch has purchased a number called MH Call. It's one of those 1300 MH Call, and is asking the 16 health services to implement it, which means we're doing it 16 different ways, which is not the best approach. The plan is that this will improve access for consumers. If you only have to remember one number, it's a crisis number, so you would still be using your day-to-day mental health, your community case managers' contact between business hours, but in a crisis there will be a number. One of the challenges we have is that the technology is not supporting the requirements of this number. So mobile technology, we share one tower for mobile technology for Brisbane with Brisbane South. So the whole of the river on Brisbane South to Brisbane North is attached to one mobile tower, which currently means that Metro South, who's about to commence using this number, all phone calls will be routed to them, which we're sort of happy about, but not really. It's a problem because the question is, well, how many people have mobile phones? Well, I think a lot of people do. And if we're future-proofing, I think people are already reducing their landlines. So we're struggling with the technology. The model is, we're committed to it, but we're struggling with the technology. So watch this space. That's something that is coming. We're required to implement it as part of the hospital and health service. I'll just continue with one of the other key recommendations from the review was that we look into a co-responder model between police and health based at the Caboolture end. So in particular, Caboolture and Redcliffe having the two emergency departments and a lot of, I guess, psychosocial and some other and psychosocial sort of issues and disadvantage. The police are often called to matters where the person may be feeling quite distressed, they may verbalise some suicidal thoughts or some anger or be a risk to themselves or others, and the police have no other option but to bring them into the emergency department. The co-responder model actually places a police officer and a mental health clinician together in the mental health service. So the plan would be that when your first responder police, your usual uniformed police officers attend an incident, their first call, of course, will be to the communications people. Their first call's to the police officer, and their second one is to this co-responder team, or a team of two. And they'll ask the co-respondent if they're known. If they're actually known to mental health, it may be that they give advice to the first responders, or they might say, oh no, we know Jimmy, it's the anniversary of his mother's death, he always gets upset this time of the year, we'll come out. And it frees up the police to go and do the break and enters and things like that. And it's actually a least restrictive approach for our consumer, so we know them. A mental health clinician and this plainclothes police officer would go out to Jimmy and they would look at a more appropriate response than being hauled up to the emergency department. So, oh really? Okay, thank you. So that's something we're looking at particularly for this end, and we have in principle agreement from the police and ambulance, the police to progress this model. This is I'll show you the dashboard if you can see the dashboard. So basically, the dashboard allows us to track on a month-to-month and a day-to-day basis how we're doing on targets around 1 to 7 day follow-up. So we know that people are most at risk when they're first discharged from hospital, and we're required to contact those people and follow up with them in that 1 to 7 day period. We haven't always done that well, but that's improving, and this is just a way of monitoring that. I won't go too much into it because of time. Yeah. The requirement for that is face-to-face. Yeah. And the targets are set because we know that some people will not want our contact, that they get lost to follow up, they move outside of our area. So we're not expecting every 100% of people to be followed up 1 to 7 because that's not realistic. But when we do, it is face-to-face. Yep. Okay. We also had a project called AQUA where we're looking at how we manage our beds, crisis presentations, looking at crisis plans for people who, again, in a least restrictive way, giving the police, with the consumer consent, a plan that says what's going to help me and what's not going to help me, who to call, who not to call. So we're doing work in that space as well, and I guess discharge planning is a lot of work yet. I wanted to show you that we are improving in some areas. So recovery plans, we look at, we've got a criteria that 100% of consumers should have a recovery plan. So this is a plan that's completed by the consumer with their own goals, and we support them to do that. Again, much the same as lots of the partners in recovery partners are doing. And I guess we are getting better. Estimated date of discharge. This is an area we're trying to get our staff to work with because we want to help people understand that the treatment time is there for a purpose and when they might expect to be re-engaged with the community, and we should be doing better as that transition, communicating that to support services. So we're looking to at least get our doctors talking to patients about, we would expect that you'll be in hospital for the next 7 days. We'll review that with you, but we expect that you'll be discharged next Friday, so that people can start planning their life. They have to pay their rent before they go back out. They have some leave. We can start engaging services. Just speed through it all. Okay. The final slide that I just did want to talk about is that we know that the NGO sector is highly motivated to partner with us. We need to get better at responding to that. And I guess the invitation today, we have partnerships like working on the Step Up, Step Down. Brett Emerson and Kylie Garrick, who's the team leader for Resource in Metro North, is going to be meeting with the partners in recovery and the chair of the Medicare Local to talk about how we can do better. So we can see opportunities when we do have a Step Up, Step Down facility about engaging with non-government organisations. We need to get better at discharging people through the week, not just on a Friday afternoon when there's no support. So we're trying to get that. The doctors they don't trust what we tell them sometimes, that there are agencies out there that they could actually discharge someone on a Wednesday and they'll be okay because more support's available. So we're trying to work at distributing discharges. Because if we discharge people or give people leave on a Friday, we might give 14 people leave on a Friday from Royal. They all come back Monday morning and it clogs up the system. So, and there's no support or less support for people on weekends. So, okay, I'd better wrap up. So hopefully you'll get access to this. I didn't talk over, time was a bit short, but I'm happy to stick around for a little while, and if there's any questions, please feel free to see me. Thank you.